So now that we've gone through a little bit, let's recap. We have a 30-year-old man with most likely, that presents with chest pain, okay? Most likely due to stable angina. But the issue that we have, the concern that we have is that this is a 30-year-old man with a family history of this, and a family history of individuals that have myocardial infarctions at the age of 30 to 40. Okay, that's a very young age. Even by Western standards, where obesity becomes a bigger issue every day, is now a diagnosis. This is still a very young age. So something else might be going on. And this is very important to remember. Okay, a lot of people will come in with chest pain and we overlook the fact that there might be an underlying problem. Okay, and these people can go home, and what happens is the next time they come back, it's too late. We can't do anything. Either they've already passed away, or it's too far, we can't repair the heart, whatever it may be, okay? So it's very important to keep the next part in mind, okay? Anytime anything comes up, when there are red flags, you should have a little light bulb in your head that says, hey, something else is going on, okay? Additionally, this is all super high yield for your board exams and everything. I mean, I had a couple of these for sure. This is something that you need to know. Because it does show up, and like I mentioned, people die because people do not remember these, and you know, they're not the easiest, but we'll try to make it a little bit easier for you. Okay? All right. So we have the liver here. That's my attempt to draw the liver, where cholesterol synthesis happens. So that's what this says. Okay. And what we are going to try to talk about is the lipid cycle. This person has stable angina, has occlusions, partial occlusions in his coronary arteries at 30. I mean, we all probably to some degree have some occlusion, sadly, but not to the point where we would have chest pain upon exerting ourselves. So, what is accelerating this process? And the place to start with this is the lipid cycle, okay? So, there are three parts to the lipid cycle, which I've tried to divide here. One is going to be the exogenous part. So anything that you kind of eat, like outside the body, comes in. This will be the endogenous. Okay. And here I call this the recycle aspect, and I'll try to make that clear as to why. Okay. But we're going to try to keep those three parts separate to make things easy. Okay. So let's start with the exogenous part of the cycle. Make this a little bit easier. So, we eat Big Mac and the wonderful Mickey D's, and or you eat a lot of olive oil with your salad, I guess. I don't know. So this is my fake attempt as an intestine. Oops, I apologize. And as you remember via histology, physiology, things of that nature, it gets absorbed and it gets made into what we call a chylomicron. Okay? So that is made into a chylomicron. And that contains all the dietary triglycerides, fatty acids, cholesterol, more or less, that you are ingesting and that you actually absorbed. Okay? And that is released with some apolipoproteins, specifically B48, very important, and C. Okay? And E will most likely be that. And what does that mean? That means that this chylomicron then goes around your body. It's in the lymphatics and then it goes around the body. And due to this apolipoprotein C, is able to activate a protein or an enzyme called lipoprotein lipase, which I'm going to abbreviate LPL. Okay? And all that does is that releases some free fatty acids from this. It's basically offloading some luggage. Okay? It's basically what like every diet tries to do, except this thing does it efficiently. And so as soon as it gets rid of this baggage over here, this chylomicron becomes a chylomicron remnant. Okay? That's all. That's the only difference. Chylomicron loses some fatty acids, it becomes a chylomicron remnant. Okay? This still has B48. It also still has C. It also has, let's find a third color. There we go. It also has what we call apolipoprotein E. Okay, and this apolipoprotein E permits the chylomicron remnant to be absorbed by the liver via an ApoE receptor. Got my stuff confused over here. Okay, so there is an ApoE receptor over here. And the chylomicron remnant is therefore taken up by the liver and can use all the free fatty acids, the glycerol, and everything for its own purpose. That right there is the exogenous pathway. Not that difficult. Chylomicron comes up due to apolipoprotein C, lipoprotein lipase takes out free fatty acids, becomes chylomicron remnant, which is then taken up due to the ApoE receptor. Okay, that's one. Now, the endogenous pathway is a little bit more difficult, but it's essentially the same thing, just different names, okay? So everything now, instead of specifically just going to the liver, is being first made, by the liver. So what first starts is the liver makes something called VLDL. This is basically all these triglycerides that are packed in there, okay, that your liver usually gets from your diet or other places in the body. Now, instead of B48, VLDL has what we call B100, okay? So, do you need to remember that? You do. But really only try to remember one or the other, okay? Try to remember maybe the B100 divided by 2, you're at B50. Close enough, okay? No one's going to make you pick between B48, B52, and B50 ever, okay? It's going to be something in there. So just remember one and either double it or divide by 2. And just remember which one's which, okay? That's how I would do it. That being said, so there's a B100. You still have your C on here. And you have an E as well. So, by using what we learned over here, this lipoprotein lipase can act on the VLDL, and therefore free fatty acids can come off the VLDL. And that's all via the apolipoprotein C. Okay? And this, therefore, becomes IDL. So same pathway than here. Okay? This still has the B100. This still has the E. And this still has the C. Okay? So that is what most VLDL will do. Some of it, for some odd reason, will just go right back to the liver. And how does it do that? Same exact way of here. You have an ApoE receptor that will accept it because it has an apolipoprotein. Hopefully that makes sense. So guess what this IDL does now? It's got the same exact stuff. So what is it going to do? Well, it could go via lipoprotein lipase, and that's some free fatty acids off, and become the infamous LDL. That's one thing it could do. And how does it do that? With the C. Okay? The other thing that it could do is much like this partner in crime up here and this partner in crime over here, it could also just get reabsorbed in the liver. And how is that? ApoE receptor. Okay? So essentially we're just doing the same thing. Even though there's all these different apolipoproteins, they really, so far, really are doing the exact same job. Okay? Alright. Now the thing to remember after this, and this is the part that makes it probably the most interesting, is that LDL now just has B100. And LDL follows a little bit different cycle. LDL can either get reabsorbed here, and by this point it's lost so much free fatty acid, this is almost like just a cholesterol droplet. But the receptor here is actually a B100 LDL receptor, okay? It does not have an apolipoprotein E anymore to be able to go in that way. So it is a E100 LDL receptor, okay? The other part of the LDL goes to these little critters that we call macrophages. Other word is scavengers, right? They scavenge the body, swallow things up that are not supposed to be there. Maybe a little bit out of the scope of this, but therefore that receptor is called a scavenger receptor. It's just, if it comes up, maybe you'll remember it. And what happens is the LDL goes to the macrophage. Macrophages say, hey, there's a lot of you. I'm gonna eat you. Just like a Big Mac, I guess. It looks good. They eat it, and what happens is they become foam cells. And these foam cells are what make up your plaques in your arteries. They go to the site of inflammation, macrophages, right, immune system. They go and they implant themselves. And that is why high LDL will lead to high foam cells and therefore high atherosclerosis. Okay? The only other thing I want to point out here is that LDL, since it is pretty much cholesterol, if a lot of it is there and a lot of it therefore gets back into the liver, it will essentially shut off cholesterol synthesis. Meaning that your liver will not be synthesizing cholesterol anymore. It will just be kind of trying to recycle it. But that also means that any cholesterol that comes in through via your diet is basically being stored. Cholesterol, but the remnants of it. Okay? So you're basically not helping yourself by just recycling LDL unless you completely cut out your cholesterol of your diet, which again would be quite the extreme. Okay? So, recap this very quickly. Liver makes VLDL. VLDL via apolipoprotein C can activate lipoprotein lipase, get rid of fatty acids, become IDL. Okay? Or it can be reabsorbed in the liver via its apolipoprotein E. IDL in its place does exactly the same thing. Lipoprotein lipase via apolipoprotein C, and then becomes LDL, or it can be reabsorbed in the liver. LDL, on the other hand, loses C and E, therefore can only go via B100, or is swallowed up by foam cells and becomes a plaque, basically. Okay? That is that. The last one's the easiest one. It's just a recycling. Liver, for the sake of our discussion, makes HDL. HDL, for the sake of our discussion, has E and C. And we'll call, instead of B, it has A. A for good. B, I guess not good, I don't know. Usually B's pretty good, but A's better. So, good cholesterol A, the others are B. Okay? And basically the only job that HDL does is that it goes and collects cholesterol that's either free-floating, it gets it from places that don't need it anymore, whether it's cells that are dying, whether it's other molecules, things like that. Okay? So what actually happens is that it goes along, and two things happen. Obviously with C, it also activates lipoprotein lipase, but the main thing that it does is that it collects cholesterol, and it does that via lipoprotein A, which makes sense. It's the only job we haven't done so far, and it's the only one we haven't seen so far. And all it does, it becomes a bigger HDL, okay? And that HDL then goes all around the body and deposits that cholesterol wherever that cholesterol is needed. If there's a new cell that needs to be done, and the plasma membrane, you need cholesterol, whatever it may be. It just, some places do need cholesterol. So it goes around, and then you have more HDL. It's still HDL. And what some of it does is it actually will just recycle, like this, back and forth, for one. For two, some of it will go back into the liver. It will bring cholesterol from the periphery back to the liver, which will then excrete it as bile acids. So the only way you get rid of that cholesterol is HDL. So in short, cholesterol out in the periphery, you bring it back to the liver and out of the body / You bring it from other places in the body to places that need it in the body via HDL, which is why HDL is good. LDL, the more you have it, the more goes into the liver, the less your liver synthesizes it, therefore the more you store, and the more plaque you have. So that's bad, that's good. Hopefully that makes sense, okay? So that is the, in a gist, more or less, the lipid cycle, okay? So let's try to talk about some diseases here. Hopefully things will make a little bit more sense when we look at this, okay? All right. So these are the 5 diseases that you should know, specifically for board exams. I will tell you that clinically 2A and 3 clearly are more common. They all have numbers. Okay, this is 2B. And I try to put them in order here, okay? All right, so let's try to break this down. Familial hyperchylomicronemia. Well, they're all inherited, okay? So not to worry there. It just means, even though there's not familial here, it's just probably somebody else that discovered it with their own name. But let's break this down. Hyperchylomicronemia. So hyperchylomicron, so lots of chylomicrons. Emia always means in the blood. So you have a lot of chylomicrons in the blood. So we're focused here, right? It's not a chylomicron remnant, it's a chylomicron, okay? So what could potentially cause high chylomicrons? Well, I think it's fair to say that it's somewhere around this step. Anything after this could be a problem. I think that's fair to say, okay? So, what here would cause that problem? I see 2 things. One would be the lipoprotein lipase doesn't work. That would make sense because if that works, then you're converting all your chylomicrons into chylomicron remnants. Okay? So if that's not working, then you can't change it to chylomicron remnant, and therefore there's an issue. So I would say that is our first one. Decrease activity of lipoprotein lipase. If you remember, lipoprotein lipase actually needs something with it. And that then is apolipoprotein C. Okay. So if apolipoprotein C is not actually made correctly, or if your body's deficient in it, whatever it may be, it can't signal to a functioning lipoprotein lipase to do its job. So that's another way that this could actually be causing a problem. So, decrease apolipoprotein C. So those are the 2 ways that you can have problems. And hopefully that makes sense. But you say, hold on a minute, right? This isn't the only place there's a lipoprotein lipase or apolipoprotein lipase C, right? We have it here, we have it here, we have it here. Why don't I see the LDL, IDL, HDL problems? Well, the issue is, remember, this isn't chicken and the egg. This is what you're eating. Your body isn't necessarily making a lot of triglycerides. It doesn't want to make a ton of triglycerides. It does what it has to do. And so most of the stuff that it's releasing here is a lot of things that it more or less absorbed. And if you're not getting past this stage, you're not really absorbing much. And so what happens? Well, what happens is that it's not really secreting as much over here. So even though this may not be functioning as well, and that is very fair to say, there's also not much being put into this pipe. And therefore, the very little that does get by, somehow in some way, shape, or form, will keep this level and this level, the LDL, IDL, HDL, at respectable levels, to the point where you will not quantifiably measure them if you were to look. Okay? But clearly what you would see is increased chylomicrons. Okay? But as I mentioned, the LDL, IDL, all those would actually be surprisingly normal. The one thing you will see, however, is you will see some elevated triglycerides. And elevated triglycerides, free serum triglycerides, not packaged triglycerides, is primarily because your body is trying to create some of those. Since it is not absorbing much, your body is trying to create. And then generally when triglycerides are in the blood, they're usually bound to a molecule. In this case, since the molecules can't be made as much because the parts are not being absorbed, therefore your body's making more, they're more free serum triglycerides. Therefore, you're going to see a lot of serum triglycerides. Okay, it's very important. It's one of the few that you will see this. And so what do you treat this with? Well, usually, I should mention that most of these people are asymptomatic. Okay? You really don't see much. I mean, you're just not absorbing stuff. It's kind of what you do, right? It's not, you're not increasing cholesterol. That's, that's what we're talking about here. So what are you going to see? So, I mean, you do have increased triglycerides. You could get pancreatitis so sometimes people will get pancreatitis. But that's anybody with high triglycerides. Another thing that people get is sometimes eruptive xanthomas, or xanthelasmas, I'm sorry. And all that is you'll see little pockets, they're kind of like red, completely asymptomatic, but they're just triglyceride pockets that some people have on their skin. Okay? So really the only thing to control are these triglycerides. So what do you give for high triglycerides? Give fibrates and niacin, because they can tolerate it. The niacin will have the added bonus, it's going to have increase in HDL. As with all these, we're always going to recommend low fat. Okay? Alright. That's the gist. Now it gets a little harder, I guess. Alright, familial hypercholesterolemia. Break that down. Yeah, hereditary, got that. A lot of cholesterol in the blood. Okay, this is one of the most common ones that you will see. So where's cholesterol? Well, cholesterol is made here, so I guess liver could be making a ton more. You could be eating a ton. That makes a lot of sense. That's true. But I'm guessing because LDL is mostly cholesterol, it has something to do with that. And so what could potentially increase cholesterol that has to do with LDL? Any idea? So, what if I say we block this? This receptor here does not work anymore. What happens? Well, the LDL still gets released. It's going to break down, it's going to be IDL, it's going to become LDL. But now LDL, instead of being able to get reabsorbed by the liver over here, it can only go to macrophages and foam cells. And that increases your atherosclerotic risk tremendously. Not only that, but by not being reabsorbed, your liver is consistently making cholesterol and consistently not shutting this down, meaning it's consistently shoving things down here with VLDL, IDL, so you have a ton of LDL just being made. A ton of it's being made. And you have more and more of this being done. Okay? So you have a ton of coronary artery disease, just atherosclerosis in general. Ton. Okay? So, we'll say the decreased beta 100 receptor activity. And so what you're going to see, as we mentioned, you're going to see a ton of LDL. Okay? You're going to see a ton of it. And so as a result, the cholesterol is also going to be tremendous. LDL is more or less the same thing. You're not going to see, surprisingly, for some people, much of a difference between HDL and VLDL. Now, HDL has nothing to do with the beta 100 receptor, it's its own system. So HDL is actually pretty normal. Why is VLDL normal? I mentioned that cholesterol synthesis is still happening. Sure. And this is still happening. Sure. But it doesn't mean that this changes anything about VLDL. It just means that when you typically have a lot of LDL, your liver would generally sense it and release less VLDL. But in this case, since LDL is not being brought back by the liver is not really sensing the high level of LDL, and therefore just releasing the same amount as you would typically see. So therefore, VLDL and HDL are within normal limits. Okay? A couple other things that you might see. You might see some elevated triglycerides. Why is that? Well, if you continuously are going through the cycle here, you're releasing free fatty acids at these 2 points. So you're consistently having elevated triglycerides. Okay? And so what symptoms are you going to have? I already mentioned some of them. Okay? So you're clearly going to have, we'll say CAD in this case, but atherosclerosis is a better way of describing it. You're going to have that. You're going to have things like tendon xanthomas. Those are where you'll see there's so much cholesterol in your blood that you're going to have cholesterol packets or balls basically being made. So tendon xanthomas are generally at the bottom, on your Achilles heel. You'll see just balls of it. You'll see xanthelasmas again, generally around the elbows. You'll see them on the buttocks. There's actually pictures at the end of this PowerPoint that you will see that incorporate some of that. And I'll talk about it then. But anytime you see those, it is a dead giveaway. That is almost patent mnemonic for this disease here, because nothing gives you such high cholesterol. These are people that get heart attacks and things like that at a very young age. Okay. And so how do you treat? Well, when you have such high LDL and cholesterol, one of the best ways to do it is with a statin. Right? A statin will block cholesterol synthesis here, actually do what LDL's job would have been had it been brought back in here. Okay? What you also do trying to lower your cholesterol is you usually use cholestyramine, I think is what it's, the term that you guys use. I don't remember. But the point is, it's something that will bind all the cholesterol that you eat, and therefore you will not actually absorb much. And that's something that acts more over here, like orlistat, things like that. Point being, you should use two things because this is such a big problem. You need to decrease the cholesterol, but you also need to decrease the synthesis of cholesterol, but also the body cholesterol in general. As always, low-fat diet is vital. Very, very important here. Okay, very important. All right, familial combined hyperlipidemia. Pretty easy here. We're just gonna say it's lots of lipids in the blood. So here is the way that this one does. So this is a little bit of opposite. It's basically the overproduction of B100. Okay, no other way. I just got to tell you that. So I just want to have you run through it first in your head. Okay, where's B100, and what would that cause? What would you see here? B100. Okay. So B100 is first made by the liver, obviously, excreted with the VLDL. So basically what you're saying is you're releasing a ton of VLDL. Okay, that's basically what you're saying. It's going to be very similar to hypertriglyceridemia. And so basically you're not stopping anything down here, okay, but you're just throwing a ton more water into the pipe system. Okay. So as a result, you're going to have increased VLDL. You're going to have increased IDL, and you're going to have increased LDL. That's just because you have more stuff in there. That's it. It's the difference between pumping out 20 of these and pumping out 100 of these. That's basically the way to look at it. And so it's not, the system does continue and it goes as fast as it can. So it doesn't, the cholesterol, the triglycerides actually do not increase to the level that it would up here. But that being said, your system still cannot keep up with the tremendous amount of formation, and therefore you will have some increase in some things. So let's figure it out. So it's going to be triglycerides, it's going to be cholesterol, but mild or moderate. We'll say moderate. Okay. So that's what you're going to see. And to be honest, again, with these, you're really not going to see typically too much. You might see the person, you're typically not going to see the level with the cholesterol, you're not going to see the level of cardiac or coronary artery disease as you would with this one. What you will see though, which is important, and probably a main distinction, is you get peripheral vascular disease. So that cholesterol is still enough to cause peripheral vascular disease, but not coronary artery disease. Meaning that our patient, instead of saying when I'm exertional I have chest pain, our patient would say, when I walk 2 miles, my legs hurt, or my leg becomes numb. That is peripheral vascular disease. Okay? That is the big difference between these two. You also get some insulin resistance, but maybe out of the scope of this course. Okay? Those are the two main things. And the treatment is going to be very similar to up here. It's the same exact thing. It's the same part of the cycle. You're increasing cholesterol. Anytime you're increasing cholesterol, you want a statin. It's not as severe as up here. So do you need a second one? You can use it. Usually you would only start on a statin. And again, low-fat diet. Hopefully that makes sense. Okay? All right. Second to last. This beta lipoproteinemia. This one should make a lot of sense. I will tell you, try to figure out what's wrong. I'm going to say you increase VLDL, you increase IDL, and you increase chylomicron remnant. Try to figure out what is going on. Give you a couple minutes. All right, you don't have a couple minutes because I don't have a couple minutes. Okay, so what is the common denominator between all these? C is one, but we already talked about C, right? That's up here. That's something else, okay? And C you can find other places. E seems to be the common denominator here. And why is that? Well, chylomicron remnant, VLDL, and IDL are all taken up by the liver via the ApoE receptor. If ApoE is not working or is not made correctly, those cannot be taken up by the liver, and therefore they'll be floating around. And so what do you typically see? So what do you typically see? Well, you're going to see increased triglycerides is going to be the main thing. And so what do we do with generally increased triglycerides? Same thing we did up here. Do fibrates, niacin, and low-fat diet, which I'm not going to write. What do you typically see with this beta lipoproteinemia? The key word that you will see on your board exam is striae palmaris. Okay? And all that is some globules, much like the eruptive, I didn't write it up there. But anyways, some triglyceride globules right in the lines and the creases of your hand. If you see that, pathognomonic type 3, right here, okay? Every time. All right, last one, hypertriglyceridemia, type 4. This one is extremely similar to type 2B. All this is actually an increase in VLDL. Okay, so much like this one was indirectly increasing VLDL via B100. This is just directly increasing VLDL production. As you would expect, you would have increased triglycerides. Okay, you would have a little bit of increase of all the other ones. Obviously, it's again you're just pumping stuff through. You're not really getting much cholesterol though in this case. Pretty much asymptomatic. Not much going on. You'll have some eruptive kind of globules again due to the triglycerides, and you do the same exact thing. Triglycerides, fibrates, niacin. Cholesterol, stat. Okay? That's what you do. Fibrates, niacin. All right. So, hopefully that makes sense. gone through the 5 most common ones, okay? To wrap this up, let's talk about what our patient has. Does our patient have increased chylomicrons? Don't know. Increased triglycerides? Probably not. He's not asymptomatic and doesn't have pancreatitis. So it doesn't really sound like he's got this one. That's weird. Okay. Type 2. Does he have increased cholesterol? Most likely. He's got CAD. Nothing that we know about tannins xanthomas or anything like that, but it seems to fit, and it's familial. So far, so good. Type 2B, increased TGA cholesterol. Okay, could be. But he doesn't have peripheral vascular disease. That's what we talked about. He has CAD. So not exactly this one either. Striatum pulmonaris? Maybe. We don't know. But cholesterol isn't really increased here. And we do know that he's got some coronary artery disease. So again, unlikely. And right here, clearly not asymptomatic. Clearly could have triglyceride increase. We don't know. But what we do know is that he does have increased cholesterol, so this is not it either. Here's our actual diagnosis. Our actual diagnosis is that this patient has stable angina due to familial hypercholesterolemia. And this is what you need to treat the patient for, not acutely, but chronically. A statin, a second agent, a low-fat diet, because if you send this patient home without any of those things, that patient will be coming back to the hospital probably within the week, within 2 weeks, within the month, and that time, that heart attack could be absolutely deadly. Okay? So hopefully you learned something in this case. Hopefully you will remember something in this case. That's the point of this. Hopefully you see why the chemistry is important for this. And come back for our next case next week. All right.